Welcome to the Deep Dive. Today, we're jumping into the Trinidad and Tobago Ministry of Health, specifically its public health system. We want to look at how it's structured, how it got here, and, well, some of the big challenges baked right into the model.
Yeah, and what really stands out when you look at the sources is this deep structural tension. There's a paradox, really. You see enormous amounts of money being spent year after year, but it just doesn't seem to translate into, better services everyone hopes for.
And that story starts before 1994, doesn't it? With widespread frustration.
Absolutely. People were really unhappy with the old, highly centralized system. Too much power at the top, not enough responsiveness on the ground.
Okay, so that dissatisfaction directly led to the big change, the 1994 Health Sector Reform Program. And the key piece of legislation was the Regional Health Authorities Act, Act Number 5. How did that act shake things up? How did it redistribute power?
It was a fundamental shift. Decentralization was the name of the game. Basically, the job of actually providing healthcare services, running the hospitals, the clinics, that was taken away from the Central Ministry of Health and given to 5 new bodies. These regional health authorities, or RHAs, NWRHA, FWRHA, you know the ones.
And they were set up to be legally autonomous, right? Independent operators in theory.
That's the key phrase, legally autonomous. So the ministry itself changed roles. It wasn't the direct operator anymore. It became, the regulator, the main financier handing out the budget, and the overall steward setting the national health goals.
Okay, but here's the bit that seems confusing based on the sources. If the RHAs are autonomous, why is the ministry still legally responsible for making sure they are, quote, properly run?
You've hit the nail on the head. That's the central governance problem. It's a built-in contradiction. The RHAs are supposed to run themselves, but the ministry is ultimately accountable. And the sources point to this causing chronic communication problems. It really hinders coordination across those 5 regions.
So the ministry holds the money, sets the goals, but the RHAs do the actual work on the ground. Sounds like a recipe for friction.
Exactly. And you see this tension reflected starkly when you look at the money. The budget growth is just immense.
Yeah, the numbers are pretty wild. It went from around, 1 billion Trinidadian dollars back in maybe 2002?
Roughly, yes. And the proposed budget for fiscal year 2024, almost 8 billion TT dollars.
8 billion. That's an 8-fold increase in about 20 years. Huge sums.
It's a massive financial commitment. And we should probably mention the pharmaceutical side briefly. A key part of their strategy involves relying heavily on cost-effective pharmaceuticals, often sourced from India, even adopting the Indian pharmacopoeia.
Right, and that funding also covers crucial things like the Chronic Disease Assistance Program, CDAP. That's a big one.
Huge. It provides free medication for chronic conditions to, I think the number is over 162,000 registered people. It's a vital safety net.
Okay, so you have this 8-fold budget increase. You have programs like CDAP managing chronic care. Yet, the public experience often doesn't seem to match the investment. The sources keep highlighting the same complaints. Long waits, not enough beds, worries about care quality. It points to that value for money issue you mentioned. Throwing cash hasn't fixed it.
Precisely. It's not for lack of trying on the financial side, and it's not necessarily a lack of people either. The RHAs employ over 20,000 staff across the board, and there's a whole regulatory system, the medical board, the nursing council overseeing standards.
So the structure, the workforce size, the regulations, they seem to be there.
Yeah.
But something's getting lost in translation, in the execution.
That's what the evidence suggests. It's about making the system work efficiently with the resources it has. Oh, and worth noting, about 15 specialized vertical services, like blood transfusion, are still run centrally by the MOE.
Okay, if you had to point to one physical example, like a symptom of this whole structural pension and execution problem, what would it be?
Sadly, that's easy. It would have to be the Kuva Medical and Multi-Training Facility.
Ah, yes, the state-of-the-art hospital. Commissioned back in 2015, 230 beds.
State-of-the-art, exactly. Millions spent. And yet...
It's sat largely empty for nearly a decade, right?
Yeah.
Except for its use during the COVID pandemic.
Pretty much. And the most damaging part, because it was accepted as complete, but then wasn't really used operationally, the warranties on all that expensive high-tech medical equipment inside, they've expired, just gone.
That's an incredible way. It's a failure of asset management, really.
Yeah.
Millions down the drain because the system couldn't get it operational.
It perfectly illustrates the disconnect between investment and operational reality.
So wrapping this up for the listener, what's the main takeaway here? It seems the core problems aren't about a lack of money necessarily, or even a lack of qualified staff.
No, the analysis really points towards a failure in strategic execution, fundamentally linked to that contradiction in the governance model. That decentralization effort created a structural hurdle. They have the money, they have the people, but the way the system is set up seems to prevent them from connecting effectively to deliver the services people need.
Okay, so on that note, let's leave you with a final thought to consider. We talked about the bottlenecks, the coordination issues, a massive budget. Given all that, just how much does the day-to-day stability of the entire T&T public health system rely on the success of that one program, the free CD app, keeping those 162,000 chronic care patients managed outside the main hospital system? Something to think about regarding where the real pillars of support might lie.